I'm Charles Peterfy, and I'm going to present a talk that I gave at the American College of Rheumatology meeting in Chicago last November about SetPoint's novel vagus nerve-mediated neuroimmune modulation therapy for patients with rheumatoid arthritis. Now, there's no question that there have been remarkable advances made in the treatment of rheumatoid arthritis over the past 25 years. But despite these advances, there still remains a significant unmet need, as many patients continue to experience disease activity despite consecutive treatment with multiple synthetic and biological disease-modifying antirheumatic drugs, or DMARDs. In fact, fewer than a third of rheumatoid patients report being satisfied with their therapy, and only a minority of patients ever attain remission, and up to a third of those who do continue to progress structurally on X-ray and MRI in what some call silent progression. So alternative approaches are still needed, and vagus nerve-mediated neuroimmune modulation is one such novel treatment that recently received approval for use in the US. Now, electrical stimulation of the vagus nerve has been used in more than 150,000 patients over the last 25 years in a variety of conditions, including drug-resistant epilepsy, treatment-resistant depression, and post-stroke rehabilitation of the upper extremities using devices implanted by neurosurgeons and ENT surgeons. The most recent application of vagus mediated neuroimmune modulation therapy is for rheumatoid arthritis. And the SetPoint system for doing this was recently approved by FDA in July 2025. But how exactly then can stimulating the vagus nerve improve things in rheumatoid arthritis? Well, the vagus actually participates in homeostasis of the immune system through cholinergic anti-inflammatory pathways and the release of specialized pro-resolving lipid mediators, or SPMs. When afferent sensory fibers of the vagus nerve sense excessive local inflammation due to infection or autoimmune causes, like rheumatoid arthritis, a corresponding signal is sent down the efferent arc of the vagus to induce circulating immune cells, including macrophages, B cells, and T cells, to downregulate inflammation. Stimulating the vagus nerve for just 60 seconds can reduce multiple cytokines by 30 to 70%. Suppression is sustained for a period of 24 to 48 hours, reducing inflammation and signs and symptoms of disease, and seemingly without the potential for immunosuppressive side effects. In addition to this partial cytokine suppression, there is also evidence that the vagus nerve acts on osteoblasts and osteoclasts in ways that could inhibit bone erosions. So this was the mechanism of action that was evaluated in the RESET-RA trial as a potential treatment for rheumatoid arthritis. The system used to stimulate the vagus nerve in this study, as shown here, and involved surgically implanting a small device on the left vagus in the neck in an outpatient procedure performed by a neurosurgeon. Radiologists use an iPad application to activate the therapy a few weeks after the procedure, and the device began automatically delivering 1 minute of therapy every day. Patients would recharge the implant once a week by wearing this collar around their neck for a few minutes. This therapy was evaluated in a double-blind, randomized controlled trial that included 242 patients with active, moderate, or severe rheumatoid arthritis despite ongoing treatment with a conventional synthetic DMARD, who had had an inadequate response, loss of response, or intolerance to one or more biologic or targeted synthetic DMARD, including JAK inhibitors. So these were particularly recalcitrant patients. Patients were washed off their biologics and JAKs, underwent the implantation procedure, and then were randomized to either treatment with active stimulation or control with sham stimulation for 1 minute a day for a period of 3 months. After 3 months, all patients received the active stimulation. joint damage was evaluated using gadolinium-enhanced MRI and baseline 3 months and 6 months. And in this presentation, we will review the imaging findings of this study. Now, the reason we used MRI instead of X-ray radiography in this study was because MRI is much more effective at detecting and monitoring change in joint damage. You can see that in this example of a high-quality radiograph of the wrist zoomed in on the capitate bone and an MRI of the same wrist next to it showing two large erosions up here that are completely invisible in the on the X-ray on the left. The MRI shows another large erosion tunneling through the lunate bone over here that again cannot be seen on that X-ray, even though the X-ray shows nice cortical and trabecular shadows. So it's not just small and early erosions, but also large, long-standing erosions that can be completely invisible on X-ray, but clearly seen on MRI. Same thing with cartilage loss. Now, the reasons for this are well known, but outside the scope of this discussion. Nevertheless, because of it, MRI has been able to demonstrate in multiple clinical trials of DMARDs over the past 2 decades statistically significant inhibition of bone erosion and cartilage loss in as little as 3 months, and with far fewer patients than would be possible with X-ray. With X-ray, it would take 6 months to a year to show this. And since FDA no longer allows patients to be kept on inactive therapy in a placebo arm for more than 3 months without rescue or withdrawal, whatever imaging technique is used to demonstrate efficacy has to be able to do it within 3 months, and X-ray just can't do that. Another limitation of X-ray is that it cannot readily detect inflammation. MRI, on the other hand, particularly gadolinium-enhanced MRI, can visualize synovitis within the joints as well as osteitis in the bones where the erosions are actively developing. Now, I put inflammation in quotations up there because what MRI actually visualizes is the increased blood flow to these tissues that is associated with the inflammation. It does not depict other aspects of inflammation, including those that actually mediate bone erosion, just the hyperemia. Inhibition of erosion progression in DMARD studies is typically associated with decreased hyperemia on MRI, but the quantitative relationship between these elements of the disease process, that is to say, how much of the hyperemia in synovium and bone marrow need to decrease on MRI before bone erosion stops progressing, is not known. And as we'll see in this study, bone erosion can indeed be inhibited and symptoms and signs of RA ameliorated without substantially decreasing synovitis or osteitis, at least the hyperemia that we attribute to them on MRI. Anyway, that is why we used MRI in this study. In fact, RESET-RA is the largest prospective clinical trial to use MRI to evaluate an RA therapy. And it's also the first structure-modifying RA therapy in history to be approved by FDA based on MRI data alone, without any X-rays, which is a precedent that's very significant and that many of us, including Mikkel Østergaard, Philip Conahan, Vibeke Strand, and others have been working on to achieve now for more than 25 years, and that we believe will greatly facilitate further therapeutic development in rheumatoid arthritis. So we're very happy about that. Anyway, in this study, we use the same MRI acquisition techniques and assessment methods that were used in previous trials that looked at biologic and synthetic DMARDs, including the same positioning frames to keep all the joints consistently aligned on the serial examinations, the same standardized MRI pulse sequences that were used in prior studies with intravenous gadolinium-based contrast, the same central image quality control criteria and process, and the same MRI assessment methods, namely RAMRIS, to evaluate bone erosion, synovitis, and osteitis, which I worked with Mikkel Oostergaard and others at OMERAC to develop more than 20 years ago. And that has been used in virtually all MRI trials since then. And Carlos, which I developed also around that time to evaluate cartilage loss in rheumatoid arthritis. And that also has been used in most trials over the last decade. The assessments were even done by the same radiologists, Yan Chen and me, who have read most of the RA trials reported thus far that have used MRI. As always, with the images in random visit order, so we didn't know which was baseline or follow-up. Subjects in this study were not required to have active intra-articular synovitis on MRI in order to be enrolled, and as a consequence, 33% lacked synovitis at baseline. So a subgroup analysis was performed on patients with more severe baseline disease and at high risk for erosion progression based on the presence of moderately severe synovitis, that is a RAMRIS synovitis score of 2 or greater in at least one joint at baseline, or at least 4 joints with a synovitis score of 1 or 1 joint with active osteoarthritis, because osteoarthritis has been shown to be the strongest MRI predictor of bone erosion. Patients in this subgroup constituted approximately half of the completer population and were referred to as the erosive phenotype, which is the focus of this report. As expected, baseline RAMRIS and Carlos scores among the patients who completed the study were somewhat lower than those reported in most DMARD studies, but values in the erosive phenotype subgroup were comparable to those of other studies, including for DAS and CRP. Most importantly, baseline values in the treatment and control arms were in good balance. Patients in the erosive phenotype subgroup showed fairly aggressive progression in the control arm with an increase in mean erosion score at 3 months that was slightly greater than that reported in most DMARD studies, whereas patients in the treatment arm showed statistically significantly less progression in the bone erosion than control, with an effect size similar to that seen in DMARD studies. At 6 months, both the treated subjects and the control subjects who crossed over to active treatment had essentially no progression in bone erosion. Cartilage loss did not progress significantly in either arm of the study at 3 months or at 6 months, which is not terribly unusual, as cartilage loss presents only after bone erosion has gotten very severe. With regards to inflammation on MRI, or perhaps hyperemia would be a more accurate way to put it, patients in the control arm of the erosive phenotype subgroup showed worsening osteitis, whereas patients who received active stimulation had statistically significantly less increase at 3 months. At 6 months, both the treated subjects and the control subjects who crossed over to active treatment had decreased to baseline levels. Synovitis did not change from baseline for either group at 3 months or at 6 months. Looking at the percentage of patients in the erosive phenotype who showed any erosion progression on MRI, you can see that 38% of patients who were sham treated progressed, while only 19 patients in the 19%, in the actively treated arm progressed. A difference of about 50%, which was statistically significant. So in closing, vagus nerve-mediated neuroimmune modulation offers a novel, non-pharmacological alternative for RA patients who do not respond to or cannot tolerate biologic or targeted synthetic drug therapies. Reset RA demonstrated that SetPoint's implantable neurostimulator inhibits joint damage and improves signs and symptoms in patients at especially high risk for erosion progression via a unique mechanism of action that modulates inflammation by harnessing more physiological pathways than do systemic cytokine blockade approaches. And with that, I'll end and in the time remaining, answer any questions anyone might have.
Excellent. Thank you for that wonderful presentation. It's always good to review this new mechanism of action that is novel to all of us.